Well, good morning, everyone. Good morning. I hope you had a great night and a great day. I had a great day. It was fantastic, I think. Welcome to the patient-level prediction tutorial. And this is an awesome tutorial, and therefore we have an awesome animation. So you're going to learn all about patient-level prediction. You saw some very nice studies being presented yesterday, and today you're going to learn how you can do that yourself. So it's going to be a very exciting day. Some exercises, some presentations from our side, and I hope you really like it. Just to introduce the faculty, so I'm Peter with the sunglasses. I'm from Erasmus Medical Center, associate professor there, health data science. And my student Ross Williams is here, and Jenna, who did a great job in building the patient-level prediction package. And Patrick, you've all seen before, I think. So the slides of this presentation, the slides are also available on the GitHub. So you can go to this address and get it there. I want to start this meeting with reading out the mission of OHDSI, which is to improve health by empowering a community to collaboratively generate the evidence that promotes better health decision and better care. So let's keep that in mind today as well. So what we're doing here is empowering you to help out in this journey on patient-level prediction in this case. And the end goal is not a machine learning exercise and learning all about prediction by itself, but it's in the end helping the patients. So we need to find prediction models that are really important for clinical care. Now this whole story starts with data, and it ends with data. But it starts with data generated by patients and patient journeys. So over time, patients generate a lot of data. And often we want to look at some moment in time and say something either about the future or something that happened before. And each of these patient journeys is unique, right? Every patient has its own journey, and we only see incomplete data. We don't always get all the data from these patients in our records. So what are the questions that we are asking during this patient journey? It can be, for example, questions like, which treatment did patients choose after a diagnosis? Or which patients choose which treatment? Or how many patients experience a certain outcome? So it's more descriptive, like data characterization. We can also have questions more in causal space, where we try to compare two different treatments or see if a treatment causes a certain outcome. Another part of the research that we do is related to patient-level prediction. And that's trying to answer the question, what's the probability that I will develop disease? Now you know all my history. Can you say something about my future? What's the probability that I will experience the outcome? So in OHDSI, we have working groups that focus on these three basic data science questions. So clinical characterization, what happened to them? Observation. Inference is patient-level prediction, and causal inference is population-level effect estimation. So if you're interested in observation or causal inference, you're in the wrong class. Right? This is all about inference. What will happen to me? Now you know all my data. So in the agenda today, you have it on your desk. We made a small change because Patrick was needed in 2 tutorials at the same time. So we will start with the exercise on selecting a patient-level prediction. And then I will give you an introduction to patient-level prediction in general. And then we go to the package and the framework, and Jenna will lead you through that. And we have a couple of exercises during the day. So I'd like to start with you, Patrick.
So what we're going to do first is an exercise to get you guys engaged in thinking about prediction problems that we might think would be clinically interesting, and hopefully identifying a clinical question that you guys think is interesting enough that together as a group we can collaborate on to try to actually develop a solution for. So Peter showed this cartoon of a patient's journey. And you have moments in time when data are collected based on the experience of a patient, their drugs and their conditions and their procedures and their measurements, and these are happening over time. Patient-level prediction, the way that we've tried to frame it, is to think about taking a patient's journey and chopping it in half. Because that moment in time times 0 is an important moment for us to think about prediction. Because if we want to predict about someone, we can use everything we know before that moment in time to try to predict what's going to happen after that moment in time. And this actually is kind of a basic but fundamental thing. And actually, we see lots of publications that get this wrong, that somehow we end up in the situation where a prediction model is really just classifying what has already happened. In the scope of what we want to define today, and as you'll work through, the goal that we have is, can we use data in the past to predict what will happen in the future? And we're going to train prediction models based off of this idea so that hopefully we could apply these models not just to data that we can see whether or not we can train a nice model, but actually apply it to real patients who have a medical history and are really concerned about what's going to happen to them in the future. So we frame this problem with a generic problem statement, which is amongst some target population, so the group at risk, we aim to try to predict which patients at a defined moment in time will experience some outcome, some event that occurs in the future during a time at risk, which is the horizon of time that we're looking for things. And this framing of this prediction problem is helpful because what we've recognized is that we can there's lots of discussion out there about lots of algorithms and lots of fancy interest in deep learning, all this kind of thing. But actually, all prediction problems can be simplified to a very basic framework, which is if you can define your target cohort, the population you're interested in, if you can define your outcome cohort, which is the event that you're interested in trying to predict, if you can define a time at risk representing the span of time that you're looking to see whether or not the outcome happens, and then what you're going to learn from Jenna and Peter and Ross is how can you develop models. If you can just define, you can fill in these 4 inputs, you can actually define and evaluate and produce a reliable prediction model. And effectively, the task that we've got is you've got a bunch of people who are at risk. Some subset of those people have an outcome, and what we're trying to do is predict which people get the outcome and which people don't. And that's the task of all prediction problems. And it turns out that with that same framework, no matter what problem, or with that same framework of a target cohort and an outcome cohort, we can address a lot of different clinically important questions. So for example, we can frame a prediction problem in terms of disease onset and progression. We could say something like, amongst people who are newly diagnosed with some disease, which of those people go on to have some complication associated with disease in some time horizon? That's a relevant question. We can also think about prediction for treatment choice. So you could say, amongst people who have an indication who are choosing between treatment A and treatment B, which ones choose treatment A? That's in fact, for anybody who's taken our estimation course, that's what a propensity score is. A propensity score is just a prediction of treatment assignment, and our framework fully supports that. We can talk about treatment response. So amongst people who initiate some sort of therapy, which of those patients actually have the desired outcome? We can also do prediction questions in terms of treatment safety. So amongst patients who are new users of some treatment, which of those patients are going to have the side effect? And again, to reinforce Peter's point, we're not talking causal inference here. We're not saying which drugs cause which effects. We're saying, for me as a patient, if I decide to make a choice of a treatment, what's the chance that I'm going to experience something in the future? We can even think about the same prediction framework supporting treatment adherence. So amongst people who start a treatment, who's going to actually stay on the treatment? All of these are valid questions that this framework can support. Oops. I guess I just described them, but just to reinforce again. So I want you guys to be thinking right now, disease onset, can you think of a clinical question that might be interesting? Treatment choice, treatment response, treatment adherence. All of these are valid prediction questions. And given that there's so many choices and we could do lots and lots of things, what I want you guys to do is just tell me a single prediction question that you think would be interesting and relevant. So I've got a handout here, and I just told you that it's really easy to create a prediction. Are they already? No, they're not handed out yet. I said it's really easy. You just need to be able to tell me a target cohort, an outcome cohort, and a time at risk, and then you yourself have defined a prediction question. So what I'm going to ask you guys to do is think of a question that you think matters. Maybe it's because you have research interest in a topic, Or maybe you have a loved one who's experienced something and you'd like to figure out what's going to happen. Or maybe you just have your own concerns about what's going to happen to yourself in the future. And what we're going to have you do is I want you to take 5 minutes now to come up with your own question. Don't worry about model specification. I just want you to come up with a clinically important question. What's your target cohort? What's your outcome? And what's your time at risk? So I'd like for you to just take 5 minutes right now, and we'll keep that up. Take 5 minutes right now and come up with your own clinical question. You guys have just defined your first prediction problem, at least in the OHDSI way, so congratulations for that. Now, most of you have written down something. It's just an idea. And what we're trying to do today is go from that idea that's on a piece of paper to code that's actually going to execute. But of course, there's a lot of you in the class, and you've all got your own different question. But my challenge is that we have to figure out which one of you's got the best question. So what I'd like to do is actually break you guys into groups so that you can share your idea with your group mates. And as a group, you guys have to decide within each group what's your one best idea that you'd like to do in this class, okay? So what I'd like to do is I'd like to ask the 5 of you guys if you could review each other's questions, and you got to come up with what is your one best question. And I think we'll do the 5 of you guys. If you guys can review each other's questions and you pick one as the best one for your group, okay? And this row in the back, you guys will be a team. So you guys got to pick one best question out of yourselves. And since it's easier to turn around, how about the 4 of you guys? So you guys can turn around. You guys pick up one best question, the 4 of you. You got that? And how about, let's see, how do we want to break this up? How about, so many permutations. How about the 3 of you guys work together? And actually, how about you join them? Okay? And then the 5 of you guys together, please. Okay? Yeah. So I want you guys to be reviewing each other's questions. What I want you to think about is pick the best one based on what you think is the most clinically impactful question that we could solve for patients. All right. You all had your own research question, your own prediction question, and now as a group, you have identified the best research question. So, now that each group has decided on their one question, we're going to hear those questions from the group. Everybody ready? Ready? All right, Peter, I think this group has the best question. Can we hear what it is? All right, everybody, it's important you guys listen to the best question ever. Okay.
And the time frame is within 6 months.
Okay. So onset of anemia. Excellent. So the prediction problem, so everybody got it. So beautiful job. And this fit the framework very nicely. We're going to take patients who have chronic kidney disease. We're going to try to figure out which of those patients are going to go on to develop anemia in the next 6 months. That is a spectacular prediction question, but I think the best prediction question's over in that group.
So the prediction question was pregnant women who have taken SSRIs during their pregnancy, how many of them go on to develop diabetes?
Okay, so for our target group, we have to be able to define a cohort and have an index date.
So
what is that index date?
I actually said first 12 weeks of pregnancy.
So what is the date that what is the moment where a woman is going to qualify, and what do we know about them before, and what are we going to see in the future? The see in the future is the diabetes.
Right.
So what's the index date that you're interested in?
Actually, 12 weeks of pregnancy, right?
So pregnant women who make it to 12 weeks. So pregnant women who make it to 12 weeks into pregnancy,
Yes.
who have taken an SSRI before the 12-week moment?
Yes.
Okay. So it's pregnant women who had an SSRI inside of the first 12 months, first 12 weeks. So the index is the first 12 weeks, and the outcome is type 2 diabetes.
Yes.
And what is your time at risk? What is the period of time that we're going to look for the diabetes?
Yeah, 6 months. So gestational diabetes. If we do gestational diabetes.
Is it gestational that we're looking for, or
Yeah.
type 2 diabetes? Which one are we, what outcome do we care about?
Let's make it gestational. Just
Okay.
really compresses the time. So,
Okay.
Yeah.
So gestational diabetes
And then gestational diabetes. So it's
in the next 6 months.
yes.
Okay, very good. That might be the best prediction question ever. unless the group behind you.
So we have 4 members. We got even votes. I will give chance to.
Okay. Thank you.
Have 5.
Yes. Okay. The target cohort is patients in Medicare in Maryland,
Okay,
and the outcome cohort is patients who had avoidable hospitalization.
okay,
The time at risk is since a patient enrolled in Medicare. The model is a discrete time survival model. Covariate diagnosis, procedure, utility, and demographics information.
okay. So can I ask you, as it relates to the population that have state Medicaid, that's what you said, right?
Medicare, yeah.
Medicaid or Medicare?
Medicare.
Medicare. Okay,
Care,
sorry.
yeah.
So for that, so what is the index date? What is the moment? What is that moment where we're going to produce the prediction? That moment where we know something about the people before and we're going to look in the future after. What is that moment for those people? What is the day that we're going to apply this prediction to those people?
Okay.
Is it
I got it.
that you're
The prediction we focus on is a probability of avoidable hospitalization in next month.
so the outcome is avoidable hospitalization. Mm-hmm. Very good. So what is that? And you said you want to look for a month. So we have a moment in time, and in a month we're going to look to see whether or not they've had an avoidable hospitalization.
Yeah, always in next month. It's scoring this cohort at the end of this month and get the score for the next month.
Okay, so you just basically want start of the month is the date for your cohort. So it's people who are in the state Medicare program on the first of every month. You want to know in that next month, are they going to have avoidable hospitalization? Mm-hmm. Okay, very good. So this is state Medicare first of the month. And we're looking for 1 month. Very good. So that might be the best prediction question, unless the group back there has an even better one.
Okay, so our target is type 2 diabetes patients who had SLG2 inhibitors as an add-on therapy to metformin and DPP4 inhibitors. And our outcome is efficacy and safety of the SLG2 inhibitors as an add-on therapy. And the efficacy would be the change in hemoglobin A1C from the baseline, and safety would be the adverse event of hepatic and renal functions. And the time would be patients who had SLG2 inhibitors for 3 years.
3 years, okay. So let me make sure that I heard it correctly. So it sounded like what we were trying to do is take people who have to step up their diabetes treatment to start on SGLT2.
Right.
And among those people, we're trying to predict which of them get HbA1c under control.
Right.
And then there's also a possible safety outcome, which is
yes.
which
adverse event of renal functions.
and which of those have decreased renal function.
Right.
Okay. So importantly here, as you're describing it, it's important, and Peter will go through it. This is one of these. As we just described it, that's a well-framed problem. It's one of these where some people will sometimes blur the line between estimation and prediction. So this prediction question will not answer the question: does SGLT2 cause HbA1c reduction or cause renal function? What it's going to say is, amongst those people who initiate that treatment, which of them go on to have that event?
Oh, okay.
Very valuable and complementary types of questions.
All right.
So let's capture that. So we've got patients with type 2 diabetes who add SGLT2 treatment, and amongst those people who go on to have, you had an effectiveness outcome, which was HbA1c reduction. And you had a safety outcome, which was renal impairment. Is that correct? And you wanted to look for the 3 years after they start that treatment. Excellent. That might be the best prediction question ever. Unless...
Okay, so on a broad level, our question is people who are suffering from major depressive disorder, MDD, which cohort in which subpopulation will go on to develop ischemic cardiac event. So the input will be newly diagnosed MDD, major depressive disorder population, and the T will be the first time that they're diagnosed. That will be the time of event, and the outcome will be ischemic cardiac event. And we also talked a little bit about what models we would use. We'll try a combination of, we'll just try between decision tree-based or regression-based models, and our parameters would be medical history and the medication that they're taking, symptoms, lifestyle events, so on and so forth. We'll just feed in everything that we've got since we're in the realm of behavioral and mental disorders.
Okay. And what was your time at risk? When you, from the time that you are initially diagnosed, when are we looking for these cardiac
3
events?
years.
3 years?
3 years, yeah.
3 years.
Yeah.
So from 1 day to 3 years.
Yep.
Well, our intention for today is to take a question and answer it. And I'm suddenly 100% sure we're going to do that. Because in Peter's slide will actually be the answer to that prediction question, because it happened to have been one of our primary OHDSI studies just a couple years ago. So we know we're going to predict that one very well. And it would be great to go through that. So we already know that's a good prediction question because we did it. I'd love to hear from the next group.
So we have a long-term safety study among rheumatoid arthritis or RA patients. And we have 2 groups. Group A taking newly started treatment A, and then another group newly started treatment B. So we want to see from the first day they start each treatment, what's their risk of cancer in the next 5 years.
Okay. So this is another good one. So what is the treatment A that you're interested in?
You can just say one is IL-6, another one maybe JAK.
Okay. So patients with rheumatoid arthritis who initiate a JAK inhibitor, was that tofacitinib?
Yeah, JAK inhibitor.
Tofacitinib, is that it?
Yeah, you can put that one.
Tofacitinib. All right, and the outcome is cancer?
Yes, so another group starts sarilumab.
And the outcome for the time at risk, when are we looking for the cancer? It's 5 years?
Yes.
Okay. So that time at risk horizon, if I start tofacitinib today, if I observe the outcome tomorrow, is that of interest? Or like when you say 5 years, when does the time at risk start and when does the time at risk
So
end?
we have 2 groups, right? One group is tofacitinib, another group is starts sarilumab, so which is another class of BDMARs. And then I would actually follow up them for as long as I could because my outcome is cancer. But usually 5 years is a minimal time that you would want to in your data set in order to see the outcome.
So you want to look at least 5 years forward.
At least, yes.
You want to look 5 years forward. Does the time at risk start the day after I enter this cohort?
Yes, when you newly started the treatment of each group.
Got it.
And then till the loss of follow-up.
So I'm going to write this deliberately here as you've got a cohort at risk, which is one of your treatments. You have an outcome, and you're looking to see whether the cancers occur in 5 years. You're describing that you have two groups, presumably because you are interested in comparing those two
there are
groups.
safety profiles
Yeah.
of the new treatment.
So you're in the wrong room for that question,
Okay.
because that's a population level effect estimation question. That's the
see.
one happening on that side of the wall. So that question is a very good one. The effect estimation question would be, is tofacitinib or two different treatments, do they have a difference? Can we do a comparative analysis to determine that there's a difference? That's a good and valuable question, and we have best practice for doing that in that room right there.
Okay, then let's do single arm then.
Yep. So the prediction question, though, is equally valuable and complementary. Instead of trying to determine if tofacitinib causes cancer, we're saying we don't know whether or not this drug causes cancer, but we'd like to know if I'm a person with rheumatoid arthritis who starts tofacitinib, am I going to be the person who gets cancer in the next 5 years? So that's the prediction problem that we could go after. And it might be the best prediction problem unless...
We kind of expected that we are going to be the best. So our question is whether taking certain kind of anticoagulants would make a significantly increase of GI bleeding. So our target population is the patients who've been taking dabigatran. It's a kind of anticoagulant for at least 6 months. So time zero will be the 6 months from the taking the medication.
Okay. And the outcome was GI bleed?
GI bleeding, yeah.
Okay, excellent. And what is the time at risk?
It's the 6 months after since starting the medicine, and until the patient is out of the medicine. So there's no kind of end time we discussed.
So the index, so somewhere this person started dabigatran, they stayed on it for 6 months.
Right.
And when they hit 6 months, that's when you're setting your index date.
Yep.
Then from the day after that,
Yep.
moving forward, you want to follow someone for how long?
Well, we didn't.
So
Maybe
like
for about 1 year.
1 year?
Yep.
Okay. So I'm going to say this is the 1 day from time zero, which happens to be 6 months from the start.
Yep.
And we're going to go until 1 year.
And the patient should remain taking the medication throughout.
That's an excellent one. So remember this picture. I'm producing a prediction at this moment in time. I get to use all the information before then, but I can't use information in the future. So I cannot do a prediction problem where I specify that you stay on the drug, because at the moment I'm going to apply the prediction, I don't know if you will stay on the drug in the future. And so this is a key challenge when you do estimation studies and stuff and we're looking at the effects. Of course, we can know how long someone's on the drug and we can follow them. If we're doing prediction studies, it's not that you couldn't do this, it's that you have to be very careful about thinking about the problem. Because if you say, what's the probability so long as I'm on treatment, you are now conditioning your problem on something that you don't know at the time that you're applying your model. Does that make sense? So very often when we think about this, we see lots of people try to produce prediction models that look to that conditioned on that time, but you have to think about how would we use that model in practice? So in practice, this is a great question that you have. I'm a person on dabigatran, I take it for 6 months, and I go to the doctor at 6 months, and maybe they're gonna write my refill, and I say, hey doc, am I gonna get a GI bleed in the next period of time? And if the doctor knew whether or not I was gonna keep taking the pill in the future, they might be able to give me a different answer. But at that moment in time, they don't know if I'm going to keep taking the pill, if I'm going to be adherent. They don't know anything about me in the future because it hasn't happened yet. So the best that you could do instead is to say, well, for people who got to that point, we can predict some time horizon that we want to look forward to. One more clarifying question for here. Dabigatran, is this for atrial fibrillation specifically?
Yeah.
Okay, for AFib. Awesome. So that is a nice prediction problem also because interestingly here, there's been a lot of published work on dabigatran and even risk predictions is that in your slides, Jenna? Do we do this one? No, we moved to the ACE one. We've previously talked about it, but what's interesting here is everybody's been focused on the GI bleed from the moment that they start the drug. The idea of actually shifting it to say amongst people who stayed on the drug for 6 months actually reframes the problem and is an interestingly different problem. Yes?
Do the outcomes have to be binary?
So the question, do the outcomes need to be binary? So in the prediction framework that we're going to do, the answer is yes. Because what you're saying is what's the probability that an outcome occurs in the time at risk. And so the one about like HbA1c reduction, for example, what we would need to do is define what is the HbA1c reduction event. You know, it would be did you observe an HbA1c less than 6 at some moment in time, yes or no? That's how we would have to dichotomize that. So we will not be doing any sort of continuous forecasting on any outcomes. Everything we're going to show you is how to do prediction on a binary. Okay, so we got everybody? Yep. Okay. So you guys all had best prediction questions, and the reason we actually have to go through this exercise is I hope you understand that you all just filled in a silly little piece of paper, but you were all able to come up with prediction questions on your own. You were able to come up with prediction problems as a group, and all of these are actually totally valid, with a little bit of modification. All of these were totally valid prediction questions that fit the same framework. And the important thing, if nothing else, that you take away from there is that we now have a framework for specifying prediction problems correctly, that if you just follow this piece of paper, you can design and you'll learn how to implement prediction questions yourself. Sometimes when we read prediction papers that are published in the literature, they get actually confusing. And so one of the things that I do when I read prediction papers is I try to decipher what was the T and what was the O and what was the time at risk. And if I can't figure that out from a paper, I'm a little bit skeptical about what it's doing. So both when you're reviewing prediction studies, but also when you're creating them, make the problem simple and straightforward. And to our experience thus far, we haven't found a prediction problem that doesn't fit this framework. And every time that we've tried to deviate from the framework, like do a case control design or something like that, we've always screwed ourselves up. So I'm very, very passionate about the fact that this framework that we've come up with works, okay? So you guys all had best prediction problems, but we've only got one day, and we said that we were going to take a piece of paper and we were going to turn it into a solution. So that means we're going to have to pick one best question that you had. So let me review them all again, and then you guys need to decide what prediction problem that we're going to solve together as a group. Okay, so everybody's going to get a vote. I'm going to read them through, and then I'm going to tally your votes so everybody remembers the questions. So we've got amongst newly diagnosed chronic kidney disease patients, who develops anemia in the next 6 months? We've got amongst pregnant women who had an SSRI in their first 12 weeks of pregnancy, who goes on to have gestational diabetes in the next 6 months? We've got amongst patients who at the start of the month are in a Medicare program, who has avoidable hospitalization in that next month? We've got amongst patients who have type 2 diabetes who add on an SGLT2 treatment, who goes on to have HbA1c reduction in the next 3 years? We've got amongst newly diagnosed major depressive disorder, who goes on to have ischemic cardiac events in the next 3 years? I'm going to actually take that one off the table only because you're going to get to see the results of that during the presentation. So we already think it's a good prediction question. So don't vote for that one only because you're going to already get to see it for free. Amongst patients who have rheumatoid arthritis who initiate a JAK inhibitor, who goes on to have cancer in the next 5 years? And amongst people with atrial fibrillation who initiate dabigatran and stay on it for 6 months, who goes on to have a GI bleed in the year, no, what did we say? the 1 year after getting to the 6-month point. Okay? Everybody know the questions? All right, let's decide which ones were. Now, when you're voting, what I want you to be thinking about too is, so you just got together and you decided what you thought was the most clinically important question. Now I want to add one more level of challenge to your thinking, which is which ones do we think we would actually have observational data available in the OHDSI community to actually answer that question? Both in terms of, is it feasible to create a reasonable phenotype for the target cohort? Is it reasonable to create a reliable phenotype for the outcome cohort? And do we think we would actually have the necessary data to do the predictors for this problem? Okay. So with that in mind, best question from a clinical perspective and from a feasibility section. Now you guys get to vote. Who wants to predict anemia in patients with CKD? Raise your hand. One. Raise your hands high so I can count them. 1, 2, 3, and another hand go. Well, wow, we could keep going all at once. Who wants to? Can you raise your hand so I can count them? Are you up or down? You're down. Okay, you're up though. 1, 2, 3, 4. Excellent. No, you get one vote. One vote. One vote. All right. Who'd like to predict pregnant women with SSRIs gestational diabetes? Raise your hand. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Wow, popular. The women of, and I saw some men's hands went up there too.
We actually had a similar question. Our question was about pregnant women. As soon as they said theirs, I'm like, well, we can't repeat theirs.
Yeah, very good. So hopefully several of you got to see. Jill Hardin had a poster that was showed at symposium yesterday that was actually taking pregnant women and predicting who had preterm birth. And we're really excited about that work. It looks very intriguing and exciting. So definitely we can think about that as well. Who's interested in predicting next month's avoidable hospitalizations? 3 in the back. All right. Who's interested in predicting HbA1c reduction amongst patients with type 2 diabetes who have add-on SGLT2? 2. All right. Ugh. Okay. Who's interested in predicting cancer amongst rheumatoid arthritis patients with JAK inhibitors? 2. All right. That was not a vote with much conviction there. It's like, I think it's a good question. It's just, and who'd like to predict GI bleed amongst patients with dabigatran? We got a big number. 1, 2, 3, 4, 5, 6, 7, 8. Is there? That's not, Johan, you already voted for the pregnancy one, right? Yeah. 8. All right. So, you guys have lots of really good prediction questions. But for today, we're going to be thinking a little bit about how would we design and implement a study to look at pregnant women who had SSRIs and whether or not we could predict gestational diabetes in the next 6 months after the 12-week point. Okay? So that will be a question that Jenna will walk you through at the end of the day. I will say that for purposes of thinking through the design and implementing that, the test environment that you're all going to have experience with will allow you to go through the design consideration. The simulated data that we have available in the test environment is simulated off of a Medicare population. So what that means is we won't actually see pregnant women unless they're really old pregnant women. It is very likely if we try to do this as a test environment that we're actually not going to have sufficient data. So what I'm going to suggest is that we absolutely go through that design exercise so you'll understand it. But for purposes of actually seeing numbers run, I'm going to suggest that we take your second option there, dabigatran and GI bleed, and we can just create cohorts for that one just so you can actually see numbers be produced. Does that sound okay? So we'll go through your design of your question, but since we know that our simulated data won't produce anything, we'll do a hot swap at the end with some cohorts to show you what it would look like.
To estimate feasibility, you didn't tell us what the data said.
Well, it's actually a good point. The simulated data is simulated data anyway, so it's kind of meaningless. Yeah. But even with meaningless, we want to be able to just show you what it looks like when it runs. So I want to do the others. But actually, if you design this study, remember, we don't do research on simulated data. We do research on real patients across the OHDSI network. So if you design this study well, I would encourage anybody who wants to take that study moving forward, bring it to the OHDSI community, and we can run that study for real. It's just that you won't be able to do it today in your fake data. Okay? All right.